presenting a case series of 3 patients. So my talk is called Eye, the Brain Spy. So tuberculosis is known to present in the eye with myriad of manifestations, and depending on the location of the inflammation, the visual symptoms are observed. Tuberculous meningitis is primarily a disease of the brain and spinal cord and has a strong predilection for the basal parts of the brain. So we present a case series of 3 young patients between the ages of 15 to 25 who presented with varying degrees of visual loss and were diagnosed with tuberculous optochiasmatic arachnoiditis. Steroid therapy was initiated in all 3 of them as per the optic neuritis treatment trial. So our first patient was a 21-year-old male who was referred to the ophthalmology OPD with a history of sudden progressive loss of vision since 10 days, which was associated with a pain behind the eyes. There was a past history of chest infection 6 years back. The documents were suggestive of pleural effusion, and on pleural tapping, there was no conclusive diagnosis that could be reached. The patient was started recently on the antitubercular therapy empirically outside. Ethambutol was given for 21 days and discontinued due to visual complaints, as the doctors there outside were suspecting that it's probably due to ethambutol. But even on discontinuation and starting the patient on linezolid for 2 days, there was no improvement in the visual symptoms. Also, isoniazid was discontinued due to peripheral neuropathy before he presented to us. So at presentation, his visual acuity for distance was HMCF and hand movements in front of face, perception of light was present, and PR was accurate in the right eye. In left eye, it was 660, improving to 636. The extraocular muscles the movements were full, free, and mild pain in all gazes. The rest of the, as we can see, the rest of the lids and the conjunctiva, cornea, and corneal sensations, everything was intact. The pupil in the right eye showed a grade 1 RAPD. There was also a color vision abnormality noted. The near vision was less than N36 in the right eye, and in the left eye, it was N12. The posterior segment on fundus picture, it revealed no abnormality. The patient was advised further perimetry, which showed bitemporal field defects and a generalized field depression suggestive of a neurological cause. An MRI brain and a visual evoked potential was advised. The OCT was normal in both eyes, and the visual evoked potential was suggestive of slowed conduction along the bilateral optic pathways. Simultaneously planned, the respiratory medicine simultaneously planned a bronchoalveolar lavage which was positive for tuberculosis, and an ATT was continued. Ethambutol and linezolid were discontinued as ocular symptoms are suspected secondary to the toxicity with ATT. Neuromedicine, the opinion was taken, an MRI brain with optic nerve cuts and CSF studies were planned, as CNS TB was one of the differentials. MRI was suggestive of TB meningitis. Inflammation found was particularly around the optic chiasma, and a diagnosis of optochiasmatic arachnoiditis was made by the neurologist. Lumbar puncture was done, and CSF findings were suggestive of TB meningitis. A clinical diagnosis of retrovalvular optic neuritis secondary to optochiasmatic arachnoiditis was made, etiology being the CNS TB. ATT was continued, and the patient was also started on IV steroid methylprednisolone, which was given for 3 days, followed by oral steroid for 11 days to reduce the inflammation. In this particular patient, the visual acuity and color vision drastically improved to 6/6 to both eyes over a period of 10 days. Optochiasmatic arachnoiditis also improved with the steroid therapy, as was observed on repeat MRI. In the second case, the 18-year-old female was referred to the ophthalmology OPD with a history of sudden progressive loss of vision since 8 days. She was a diagnosed case of TB meningitis and had a history of ICU admission for the same. And she was already on antitubercular therapy. So at presentation, her visual acuity was also impaired in both the eyes, but the extraocular movements were painless. There was a grade 3 RAPD present in the right eye, and the color vision could not be assessed as the near vision was less in both the eyes. Posterior segment picture again revealed no abnormality. Investigation showed an abnormal OCT with RNFL thinning, and MRI brain was done, which showed tubercles around the optochiasmatic area. The ATT was continued. The patient was started on IV steroid, again for 3 days, followed by oral steroid for 11 days as per the ONTT trial guidelines to reduce the inflammation. She showed no improvement and eventually progressed to no perception of light in both eyes over a period of 10 to 12 days. Case 3 was a 25-year-old female, again referred to us with a history of sudden progressive loss of vision in 7 days. She was again a diagnosed case of TB meningitis and was on ATT since 2 weeks. At presentation, again, her visual acuity for distance and near was impaired. There was a grade 1 RAPD in the pupil, in the right eye pupil. And we did an MRI brain, which again showed multiple tuberculomas around the optochiasmatic area. And IVMPS was started along with the treatment in conjunction with the physician and continued for 3 days. And then she was shifted to oral prednisolone. She improved to 624 in the right eye and 636 in the left eye over a period of 15 days, and no further improvement was observed beyond this. So, Mycobacterium tuberculosis can cause inflammation in any part of the eye, leading to corresponding visual deficits. It is therefore imperative to localize the site of inflammation so that the necessary treatment can be started. So, according to a study in the profile of optic neuropathies in TB cases, 5% of the cases are found to have retrobulbar neuritis. In a study published in Neurology India, 14% patients of TB meningitis showed optochiasmatic arachnoiditis, but the association with visual symptoms was rare. So, in conclusion, ocular manifestations should be watched out for in all patients of both pulmonary and extrapulmonary TB. So in this particular paper, I want to highlight the part where we do an underlying checkup for all the patients who are diagnosed with respiratory TB and also with TB meningitis before starting the ATT. A baseline evaluation is done, but also the patient, once the treatment is started, it is often seen, it has been mentioned in certain papers, that once the treatment is started, there is a paradoxical worsening of the optochiasmatic arachnoiditis if it's a TB meningitis patient, and there are further visual symptoms observed. So, a pre-ophthalmic workup and a regular ophthalmology follow-up when on ATT should be stressed upon, as ocular toxicity is seen with the in about 5 to 6% of TB patients in standard HRZD. And yeah, these are my references. Thank you.
Regarding anti-tuberculosis treatment, yes, you excluded ethambutol and INH, right?
Yes, sir. Yes.
So, how many in multi-drug therapy of ATT? How many drugs you have given for cerebral TB?
Sorry, sir.
Cerebral tuberculosis.
So, sir, in there's an intensive treatment and a continuation phase. So, the first is the intensive treatment in which the 4 drugs are given, which are HRZD.
What are the drugs you preferred in those cases? In these 3 cases.
In these 3 cases, sir, actually we changed the ethambutol and the isoniazid and changed it to linezolid. Okay. But linezolid, since we had given it only for a very short duration in the first case, so we couldn't really see, because linezolid also has ophthalmic complications. But it was definitely observed that as soon as his treatment was initiated, his visual symptoms were observed in very close to that period. And according to certain papers, since these optochiasmatic arachnoiditis has not been mentioned much in ophthalmology papers, from what I saw, it has been mentioned more in neurology papers. So they mentioned that once you give the treatment, there is a paradoxical worsening in the visual symptoms and also of the symptoms in general of the TB meningitis. So it's best that you start the steroids early. There is always an unpredictable outcome, because most of the papers that I read, they said that they do not improve to 6/6. But in our case, the first patient, he improved to 6/6 and with a wonderful color vision improvement.